Thank you for joining us for today's webinar, The Role of the Pharmacist in the Management of Substance Use Disorders. My name is Marla Kaufman, and I'm the Communication and Health Promotion Associate at IRETA. I will be moderating today's webinar. I would like to go over some quick housekeeping items about how to use the WebEx technology and how to access continuing education credits. First, we would like to encourage you all to participate in today's webinar in a few different ways. If you have questions for our presenter or are experiencing any technical issues, please use either the chat function or the Q&A panel to communicate your questions. Our presenter, Dr. Janet Astle, will take questions at the end of the webinar. Feel free to submit your questions through the chat or Q&A box at any time. This webinar is approved for 1.5 PCB and/or NADAC credits, which are free. A certificate of attendance will also be available to download from your MyIRETA account. Please take note that it will take up to 48 hours for your CEUs and certificates to be available in your MyIRETA profile because we have to cross-check your attendance with WebEx following the webinar. After the webinar, you will receive several follow-up emails. The first will be an email that will include a link for the evaluation form for the webinar, as well as more information on how to access your certificate of attendance and continuing education credits. We may send you an additional email to remind you of the evaluation. I would now like to introduce today's presenter. Janet K. Astle, BS Pharmacy Ed.D. currently serves as the Assistant Dean for Student Services for the Duquesne University School of Pharmacy. In her role as Assistant Dean, Dr. Astle oversees areas dedicated to student support services, professional student organizations, government relations, admissions, and advisement. In addition to her responsibilities to the Office of Student Services, Janet Astle serves as coursemaster for the continuous professional development series of courses that run throughout the professional phase of the Doctor of Pharmacy curriculum. She currently serves as advisor to the student chapter of Phi Lambda Sigma Pharmacy Leadership Society. She earned her BS degree in pharmacy from Duquesne University in 1980. Upon graduation, she worked in community pharmacy practice for Thrift Drug Company and provided consultation services for a skilled nursing care facility. She also researched, authored, and produced 30 distinct state pharmacy law manuals for the corporate entity. In 1996, Dr. Astle accepted a full-time position with the School of Pharmacy at Duquesne. Most recently, she served as its Director of Experiential Education. Okay, Dr. Astle, if you are ready, I will pass things over to you.
Thank you very much, Marla. Hi, everyone. Thank you for joining us today for our presentation on the role of the pharmacist in the management of substance use disorders. As Marla mentioned, I am the Associate Dean for Student Services at the School of Pharmacy at Duquesne, and I am also a licensed pharmacist in the state of Pennsylvania. So I am joined today by 4 of my students, Hannah, Sean, Caitlin, and Temple. They are in their 6th and final year of the Doctor of Pharmacy Professional Degree Program. None of us have any significant financial relationships with commercial entities to disclose. So before we get started, we wanted to pose a question to the audience, and you can type your responses in the chat. But what comes to mind when you think about the role and the responsibilities of a pharmacist in general? So we'll wait a few moments while you type those into the chat.
I'll read those out to you as they come in too. So we have counseling, fill prescriptions, harm reduction, medication control and management, advising consumers of potential contraindication of medications. Hold on, they're coming in fast now. Helping to address treatment barriers, identifying drug-related problems, providing medications and instructions for them, immunizations, prescription drug monitoring programs, and educating patients.
Great, thank you very much. So those are excellent responses. And, it seems like many of you have a pretty good understanding of what pharmacists can provide. So, what we are going to drill down to today is we are going to talk about the education and training that prepares pharmacists for expanded roles in a wide variety of practice settings. We will talk about ways pharmacists can screen for and identify individuals at risk for substance use disorders as frontline providers. We'll talk about ways in which pharmacists can move individuals towards behavior change through motivational interviewing, warm handoffs, referrals, and long-term coaching and support. We'll talk about the role of the pharmacist as a member of the healthcare team in managing and monitoring medications for substance use disorders. And then we're going to talk about how pharmacists can help to dismantle stigma and overcome those barriers that get in the way of providing optimal patient care. So at this point, I'd like to hand over the program to one of my students, Hannah Dobbs. And Hannah is going to talk about the education and training that pharmacists are undergo so that they're prepared for their expanded roles. Okay, Hannah.
Okay, hi everyone. Thank you so much for tuning in. As Dr. Astle said, my name is Hannah. I'm in my 6th year along with the other students. So just to kind of begin, some of the education and training that student pharmacists go through to be prepared for these expanded roles, like we talked about, is 6 to 8 years, depending on the university of education. And then the next slide will kind of go over what that education includes. And then you graduate as a doctor, as a PharmD. And then some student pharmacists do choose to go on through continuing education programs such as residencies and fellowships, which would allow them to kind of specialize in different areas of pharmacy that interest them. Okay, so this looks a little overwhelming, but here is kind of like the baseline curriculum that most pharmacy schools go off of. So on the left-hand side is the pre-professional, and that's kind of your basics like biology, chemistry, organic chemistry. And then the right-hand side is more of the professional phase, which is like where we kind of focus more in on pharmacology and pharmacy. So you can see over far right corner is therapeutic. So those are all the classes that we learn about medications, disease states, treatment, screening. So that gives us a very wide knowledge of a lot of different disease states. In the center, we talk about ability-based labs. So not only are we learning about all these different medications, disease states, different ways to treat, we also practice it in the ability-based lab. So that's a big proponent, like in the endocrine class, we talk about insulin, and then in ability-based lab, we talk about how to inject insulin, how to counsel a patient, and then we even inject saline to kind of practice and know how to coach a patient through it. And so at the bottom is experiential education. So these are programs where each summer in between the professional phase years, we go to different sites. So IPPE stands for Introductory Pharmacy Practice Experience. So the first year we do a community pharmacy such as Rite Aid, CVS, Giant Eagle, where we learn community pharmacy and the flow of practice there. The second year we do hospital, which we would go to hospital and kind of learn the basic practice skills there. And then in our 6th year, there is numerous different rotations that we call APPEs, which is Advanced Pharmacy Practice Experience. And this is longer experiences. So the IPPEs are about a month experience at different practice settings, where the APPEs are 5 to 6 weeks, where students can really dive into a different area of pharmacy and really get a lot of practice in that area. And that prepares us for graduation. Okay, so pretty much there's a couple different ways to get a PharmD. What we're all in is the kind of the in-person, where we're 100% in person for classes, for labs. They do offer a hybrid mode, so pretty much that has online classes, but there's still an in-person practice because, as we said, being a pharmacist is not about just learning in class, it's about practicing and being able to counsel patients and talk to patients. So the hybrid mode has online portions, but then they also come in person for like the lab portions and different things that can't be delivered online. So like I said, we cover a lot of different therapeutic classes, and in each one, for every drug we cover, we talk about pharmacodynamics, pharmacokinetics, drug elimination, mechanism of action, and effects on the body's receptors. So we have a very specialized knowledge in every drug we talk about. And then just more focus on substance use disorders. There's a lot of different certificate programs that you can complete to kind of really hone in and know as much as you can about substance use disorders. And there's a substance use disorder certificate, opioid stewardship, MI and SBIRT certificates, and CE opportunities. Okay, so when you think about pharmacy or pharmacist, there's probably some traditional roles you think of. So community retail, this would include things like offering advice on dietary supplements and OTC products. We have a whole class that specializes in that, administering vaccines. And then kind of as we talked about in the chat box, like barriers to treatment would be insurance issues. So pharmacists have a knowledge where they can resolve those issues to make sure patients get their medication efficiently and as affordable as possible. So then kind of the other one you probably think of is hospitals. So there's a lot of different roles that hospital pharmacists complete. So formulating IV dosage forms for specific patients, renal dose adjustments, and antimicrobial stewardship. These are all kind of areas that pharmacists play a big part in, but there are many roles you probably didn't think of, but listed on the screen are just some of the very many roles that pharmacists can play and be a really important role on the healthcare team. Okay, so now I'm going to kind of go into things that you might know that a pharmacist can do, but you might also not. So just to kind of give everyone like a brief overview. You've probably heard that pharmacists play a big role in immunization, especially with the COVID-19 pandemic. So every pharmacist can vaccinate, but depending on the state, it changes which vaccines are allowed and if a prescription is required. So the benefits for pharmacists being able to vaccinate would be increased vaccination rates. Pharmacists, as we're going to talk about, are really accessible. They're a first-line member of the healthcare team. So they can talk to people, they can kind of decrease misinformation around vaccines, and also they're safe, cost-effective, and efficient for preventing illness, disability, and death. So some examples of vaccines that pharmacists can give are the COVID-19, influenza, pneumonia, and tetanus. In addition, just as a side note, pharmacists have a very unique expertise in travel medicine. So if you were to travel outside the country and you had some questions on which vaccines you should be getting, are there any like prophylaxis medications you should be on, your pharmacist is always there to answer any questions, and you can go and talk to them about what you could need to travel outside the country. And then this map just kind of includes a breakdown of what each state requires. So the dark blue is that the pharmacist can prescribe a vaccine. The light blue is that the pharmacist can prescribe a vaccine in relationship with a prescriber protocol. And then the light blue is that a prescription is needed for a pharmacist to give a vaccine. Okay, so point of care testing is another area that pharmacists play a role in. So pretty much this is accessible testing that is performed by a qualified staff member that produces these rapid results. So some of the examples that you might think of is hemoglobin A1C levels through a blood stick sample, rapid influenza test, and the COVID-19 antigen test. In some states, depending on the rules with pharmacists prescribing, if a pharmacist is able to prescribe, they would be able to prescribe Paxlovid for a patient that tests positive for COVID-19, and this would just kind of hurry up the treatment, the time to treatment, which would improve outcomes. So some benefits of pharmacists being able to provide point of care testing would just be limiting barriers to treatment. They'd be able to kind of tell like faster if a patient needed treatment, and then it also limits the patient burden on physicians. Okay, so a big area that all pharmacists play a role in is medication therapy management. So there is a kind of a need for this medication therapy management because it's estimated there are about 1.5 million preventable adverse events that occur yearly, and this results in $177 billion in injury and death. So medication therapy management is kind of an umbrella term, but some things that it includes is personal medication record, medication-related action plans, intervention and referral, and documentation and follow-up. So the goal of MTM is to make sure that the medication is the perfect fit for the patient, their health condition, and their desired outcome. So MTMs can be done by any pharmacist in any setting, but some patients that would probably benefit it from the most would be patients who take several medications, have several disease states, have questions about their medications, take medications with close monitoring such as warfarin, and have been recently hospitalized or obtained their medications from numerous different pharmacies. Okay, so transitions of care is another area that pharmacists play a specific role in. So transitions of care is when a patient moves from provider to provider or setting to setting. So an example of this would be moving from hospital to home or home to hospital. And anytime there's this transition, it puts a patient at increased risk for an adverse event. So pharmacists can evaluate risks that impede access. So this would be like if a patient was moving from hospital to home, making sure that they're able to get their medications in a timely manner. and then improve adherence with their medication. So educate them on the purpose of it, how they're going to take it, and then prevent medication errors just to be able to say, hey, I got this patient's prescription. Let me ask you some questions just to make sure I understand how they're taking it, to make sure that I can help the patient best. So pharmacists do safeguard the patient's health and safety, and this also reduces readmission rates to the hospital. And so then another activity that pharmacists can engage in is collaborative practice agreements. So collaborative practice agreements are an agreement between a pharmacist and a physician, and some tasks that they can delegate to pharmacists include initiating and modifying and discontinuing medication therapy, chronic care management, refill authorization, and formulary management. So pretty much why this is so great is because it kind of improves efficacy and effectiveness of the care delivered between the healthcare team. It increases access to care, so patients can come talk to the pharmacist, just to kind of decrease the burden on physicians. It expands the services that are available to patients through allowing them to go to the pharmacy. And this really leverages the pharmacist's expertise on medications, and it complements the knowledge of their healthcare team. And then this is kind of just a chart to kind of go over which states allow. Similar to the vaccinations, it's kind of state to state dependent. So the dark orange is that drug therapy management is available in pretty much any setting. The lighter orange is available in limited healthcare settings. The striped is that the management given is very limited, so it'd be like vaccinations and emergency contraceptive. And then white is that there's no laws that identify or that the legal authority is unclear.
Thank you, Hannah, for providing us with that broad overview of the role and responsibilities of a pharmacist. As you can tell, we're playing musical chairs here. What I'd like to do now, before we drill down into the specific role of the pharmacist in working with patients with substance use disorders, just a very brief recap of where we are now in terms of the current overdose crisis. So, first of all, back around the year 2017, prior to COVID pandemic, we were alarmed. We were alarmed when we saw more than 70,000 deaths attributable to drug overdose in that year. We were a little bit hopeful in 2018 because we saw a little bit of a softening of that, between 67,000 and 68,000 deaths per year. And then COVID hit. So we just saw an astronomical increase from 2019 to 2020, year to year. There was a 30% increase in the number of deaths associated with drug overdose. In 2021, post-COVID, we set a new record, over 107,000 deaths. This is staggering. Since 2018, there has been a 61% increase in overdose deaths. Our provisional data from the CDC for 2022 does show a little bit of a decline, but not much. We've kind of flattened that curve a little bit, still well over 100,000 deaths. Now, most of those deaths, more than 2/3 of them, are attributable to opioids. So if we go back to look at what happened since the 1990s, here's a great graph that kind of demonstrates that. So we saw a big uptick, an increase in the number of prescriptions being dispensed for prescription opioids due to a lot of factors, which we will not have time to delve into today, but some of that related to deceptive marketing practices. So folks were overprescribing opioids. They were very liberal in the use of opioids. When we began to recognize that this was contributing to deaths around the year 2010, we saw that folks now recognized the problem and began to pull back on the number of prescriptions being issued for pain management, the opioid prescriptions. But what happened is many people now were dependent on opioids. So if you can't get your prescription anymore for an opioid, what do? You turn to the streets. And guess what? There was a very cheap, readily available alternative called heroin. So we see this big, sharp increase in the number of overdose deaths attributable to heroin. And then while it just really took off, when we saw an infiltration of fentanyl and fentanyl analogs now adulterating the illicit drug market. So you can see this astronomical increase now in overdose deaths because of the high potency of fentanyl. Okay, and now I'm going to hand over the program to our student Sean Kerrigan. And Sean is going to begin talking about the pharmacist's role, particularly in screening and referral for substance use disorders. Okay, so Sean.
Thank you, Dr. Astle. And thank you again, everyone, for joining in today to hear our talk. And as Dr. Astle mentioned, I'll be looking more in depth with the pharmacist's role in screening and referral for substance use disorders. So we kind of went over this at the beginning a little bit, but I just kind of put down like a general thoughts here at the beginning of my part here. When you think of what pharmacists typically do in the pharmacy or out in the field, what a majority of people think about is a couple of things. One being the fact that pharmacists are kind of known for being medication experts and handling medications, right? So they kind of know what the medications are used for, the brand and generic names of the medications, specific side effects to look out for, when to know if the medications are working correctly. And they're also kind of known for offering preventative services, which Hannah went over a little bit earlier with. For example, giving immunizations, right? They could also offer advice to patients on how to monitor their blood glucose levels, how for patients to monitor their blood pressure levels, right? And the importance of this is that it can lessen further healthcare costs in the future by preventing such things such as like hospitalizations and that, because they've offered these preventative services. But in terms of what's known to a lesser extent overall for pharmacists is their accessibility to the public. And I put down a couple of statistics here that we found. There are community pharmacists in every state congressional district in the United States. There's a pharmacy within 5 miles of 90% of Americans. And with this, pharmacists are actually ranked as the most accessible healthcare professionals. And pharmacists are also ranked among the most trusted healthcare professionals. And accessibility is an important point here, just because with how accessible and how close pharmacists are to a lot of Americans within the United States, people are able just to kind of walk into pharmacies to ask their questions or kind of seek advice from pharmacists at no charge. So instead of having to make an appointment or something with the healthcare professional, patients are able just to freely walk into a community pharmacist, go to the consultation area, and ask whatever questions might be coming to their mind to the pharmacist and get sound advice from the pharmacist as well. But in terms of kind of managing substance use disorders, pharmacists play a big role in screening or in being able to screen and identify any kind of risks that are associated with these substance use disorders. And as somebody mentioned in the chat a little bit earlier, one of the big things that pharmacists can utilize in this is PDMPs, or prescription drug monitoring programs. And for anyone who's unaware of what a PDMP is, these are all state operated databases that are used to collect information on certain medications that are dispensed. And specifically, they usually track prescriptions for Schedule 2 through 5 controlled medications, but some specific states will track unscheduled medications that have a high misuse potential, such as, for example, ephedrine that can be used to create methamphetamine. But then with PDMPs, pharmacies are actually required to submit data to their state-specific PDMP for each prescription that they dispense for a specific controlled substance that is being monitored. And the information that is collected with these PDMPs, I put a little bit down here what is usually collected. The date that this medication was dispensed, for example, the patient who is receiving this medication, the prescriber who wrote for the medication, the pharmacy itself that is dispensing the medication itself, and then the overall quantity of the medication that is being dispensed. And with these PDMPs and looking at this information itself is really important because pharmacists are able to kind of look at the information that is being collected and gathered. And if they see what we consider any kind of red flag with the potential for substance misuse, for example, pharmacists are able to kind of see this and maybe discuss with patients any kind of concerns that they might have. And a couple of red flags I kind of listed here that are commonly seen in the pharmacy setting are things such as early refills for medications. If a patient says that they lost their prescription itself, any kind of similar prescriptions that are being coming in from the patient from different doctors, we refer to this as doctor shopping. If a patient comes in with the same or similar prescription from and going to multiple pharmacies to fill this prescription, we consider this pharmacy shopping. If the prescription looks like it's been forged in any way, such as maybe the quantity of the medication or the strength seems to have been altered, We look at these like as forged prescriptions. And also, if the patient seems to be paying in cash instead of through insurance, this is also a big red flag. But it's important to kind of note that just if you see these red flags, for example, in the pharmacy, that doesn't mean necessarily that there is any kind of substance misuse that is going on. It just kind of warrants further investigation. For example, if a patient is coming in for early refills, it might be because the patient is going on vacation and they just need the extra refills to kind of get them through the vacation time. If the patient is coming in and is paying for cash, the reason might be that something like GoodRx or something like that might actually be cheaper to get the medication instead of through their insurance itself. So this is just something that we kind of need to look at as pharmacists to kind of get the whole picture of what's going on. The PDMPs can also play a big role because pharmacists can flag suspicious prescribing patterns. So if multiple prescriptions are showing illicit or unsafe prescribing by medical professionals or prescribers, pharmacists can use this to kind of flag this and kind of make sure that the patient is being safe and that there's no substance misuse going on. Another big part with screening and identification of risks with pharmacists is the idea of SBIRT, or referred to as screening, brief intervention, and referral to treatment. And SBIRT is a really important process that pharmacists can use with identification of risks and screening. And what SBIRT is it's an evidence-based approach to identify individuals using alcohol and other substances at risky levels. And there's a couple processes that you can use with SBIRT. One of the first ones you'll use, though, that pharmacists can use is something known as a pre-screen. And this is just a short questionnaire that's relating to alcohol and other kind of drug use that would be administered prior to beginning any kind of full screening. And there are a lot of different pre-screens that pharmacists can use, and I just added a couple here. And then on my next slide, I have kind of more of an in-depth look at what a pre-screen might look at. But two of the bigger ones you might see are the Audit C, which is just a 3-question test that's a pre-screen for any kind of alcohol use disorder. And there's also the DAST-1 test, which is just a 1-question test used for drug use identification. But as I said before, there are lots of different other pre-screening tests that you could consider using, and it's kind of up to the pharmacist to kind of find the ones that they're most comfortable with and using in their practice. But for the pre-screen, depending on the overall outcome of the test, pharmacists can then move on to administering the full screen. And here I just have an example of what a pre-screen might look like. It's important to note up at the top here, for this specific pre-screen, it kind of gives the idea that you're telling the patient that this is something just standard practice that you administer to all your patients. So the patient won't feel singled out by receiving this test, and they might feel more willing to kind of answer fully, truthfully, and correctly to this information that the pharmacist is presenting. And in this pre-screen here, it's just a 1-question test for each. They have an alcohol-related question and a drug use-related question. The alcohol one being, how many times in the past year have you had 4 or more drinks in a day? And then the drug use test saying, how many times in the past year have you used a recreational drug or used a prescription medication for non-medical reasons? And for this specific pre-screen test here, any answer for either of the two that is anything other than 0 would warrant moving the patient on, and they'd be eligible to take the full screen test. Now with the full screen test here, and I just put 2 of the more common ones again, will be the Audit and the DAST-10. So these are the further moving on portions of the Audit C and the DAST-1 that I mentioned earlier, that were 3 and 1-question tests respectively. The Audit test here would be a 10-question test for alcohol use disorder screening, and then the DAST-10 full screen test is a 10-question test for drug use, any kind of drug use disorder screening. And the score on this test will determine the action, the risk level, and the intervention that the pharmacist can take here. And kind of warranting or based on what the score would be, you could see the intervention being brief education, which would just be kind of talking and discussing with the patient what some of the risks might be if they continue to use any kind of the substances as they are, and maybe what some of the benefits might be for lessening some of the use and any kind of help that the patient could seek to receive. You could also see brief intervention being used by the pharmacist and referral to treatment, which we'll get into just now. So brief intervention is a big piece of what pharmacists can do in the pharmacy, and it's used to initiate a change for unhealthy or risky substance use. And a major part of what pharmacists can use or utilize with brief intervention is the idea of motivational interviewing. And this is a big, big piece that pharmacists can use pretty much in their everyday roles as a pharmacist, whether it's in the community setting, in the hospital setting, or wherever else they may be practicing. There's no real set kind of guidelines of how someone should utilize motivational interviewing, but I kind of just put like a general idea here. It's always important for pharmacists to ask for permission to discuss any kind of screening results with the patient that they saw. because you want the patient kind of feeling comfortable with the discussion itself. If you're just kind of throwing the information onto the patient, it's not very likely that any information you're giving might stick with the patient and might warrant any kind of behavior change for the betterment of the patient themselves. But there are a bunch of different processes that you can utilize with motivational interviewing. One of the big ones that we use in the pharmacy is the idea of the readiness ruler, which kind of discusses how ready the patient is to make a change in their alcohol or substance use frequency. And then based on their readiness, you can kind of tailor an agreed upon or a jointly negotiated plan with the patient to maybe make some kind of a change in their lifestyle. You could also categorize the patient into their specific stage of change, kind of for the same purpose of kind of seeing where the patient is at, and then you can make that jointly negotiated plan with the patient. And these are the main five we typically see in the pharmacy with the pre-contemplation phase, the contemplation phase, the preparation, the action, and the maintenance phase. And that kind of goes from pre-contemplation and contemplation, where the patient might not be ready yet to make a change and really isn't considering a change in their lifestyle, all the way up to preparation and action, which is the patient is pretty ready to make that change and is looking for some guidance on how to make that change. And then once they make that lifestyle change, the maintenance phase is kind of trying to keep the patient on that pathway to making that change, not falling back to any kind of previous use. And the big idea is you want to move that patient along what we consider the trans-theoretical model of change. And this idea basically explains and predicts the patient's success or failure in achieving a proposed behavior change with the patient. So we want to move them further along through a jointly negotiated plan again, so that the patient is continuing to make that change and is maintaining that behavioral change. And I mentioned it a couple of times, but once again, the big idea here is you want to develop a jointly negotiated plan with the patient. You don't just want to throw what you feel might be the best plan for the patient onto them. You want to kind of gauge where the patient is at and then see what they'd be willing to try and do, so you can have more possibility of a success or of a successful behavioral change with the patient. And then after the brief intervention in the motivational interviewing phase, pharmacists can refer the patients to treatment. I listed a couple of different things here with how you could refer a patient or find different treatment sites. A national site you could use is the Substance Abuse and Mental Health Services Administration, or the SAMHSA website. And on this website, there's a Find Treatment tab. And if you put in a little bit of patient information, such as like location and all, this tab will actually provide you with the name and type of the site that the patient might be able to see, the website for that site, the address, the services that are provided here, and if there is a payment required, which kind of payments are accepted and which kind of insurances are accepted. If you're not looking to use the national route, there's a couple of other options you could do as well. You can use your specific state or county drug and alcohol programs. Here in Pennsylvania, we have something called the DDAP, which is the Department of Drug and Alcohol Programs, and that will help the patient, same kind of idea, find a treatment option that is close to them, based on what the zip code is that they put in or what their county is for their state. And then also you could use local treatment centers. And I put this down here as well for any kind of, I put it specifically for local treatment centers, but this could go for kind of any treatment center that you utilize. It's important for pharmacists to kind of be able to form a relationship with different healthcare professionals in these different centers, so they can have confidence in referring their patients to the proper care and knowing that this is a good site for the patients to go and seek treatment. And then I also put down here that pharmacists are also can offer support resources for patients. And it's important to note that not all patients need to be referred to treatment. Some patients might do well with just support resources. So it's important for pharmacists to be familiar with these as well. They could offer support with recommending that patients maybe go see or attend different kind of meetings, such as NA and AA meetings. So these patients are able to kind of discuss their own experiences and find support with different people in these programs as well. And this is also an important one as well, because these meetings are also offered online. So if the patient has any kind of barriers with transportation or anything like that, they can do these right from their own home and seek any kind of support resources that they may need. And the last thing I'm going to discuss real quick here is the idea of medication disposal. And this is a topic that's not thought too much about, but when looking at medications themselves as well, knowing how to properly dispose of any kind of used or expired medications can be pretty difficult. A lot of thoughts come in is, can this be flushed? Can this medication be thrown away? Not really sure what I'm supposed to be doing with this medication if I don't use it. And pharmacists can help a lot with this. It can counsel patients on the proper disposal of these medications. Like I said, knowing which ones can be flushed, knowing which ones can be thrown away. There are also DEA approved specific drug take back program days, which occur at the end of April and the end of October that pharmacists can recommend patients kind of go towards. And another big one is, besides just kind of counseling the patient on where to look for, um, specifically on the medication itself or where it can be disposed of, such as on the drug label itself or the package insert sometimes will say how to dispose of the medication. You can also help the patient look up, I put down here as a resource, the US Department of Justice and the DEA Diversion Control Division website actually helps the patients find specific collector locations. And what you would do is you would put in the patient's zip code or their city or state, and this would give you a variety of different take-back locations within a 5, 10, 20, or 50-mile radius. And a lot of these will just end up being at like a specific community pharmacy near their house. I know CVS has a drug take-back box that if you walk in and ask the pharmacist to unlock, they'd be happy to unlock it for you so you can dispose of any medications properly.
Thank you very much, Sean. So next up, we have Caitlin Newrider. And Caitlin is going to talk to us about the role of the pharmacist in the medication management of substance use disorders. Caitlin.
All right. So like Dr. Astle said, I'll be talking a little bit about the medications here. So first I wanted to talk about naloxone rescue, as I'm sure many of us have heard about. Specifically naloxone, it works by acting as a competitive antagonist. So it actually has a higher affinity for the opioid receptors than the opioid themselves. So when you administer the medication, it'll actually kick off that opioid and block its effects. And it will also reverse any of the effects we're trying to block that we typically see with overdose situations, such as like the respiratory depression. So depending on which state you're in, many states have a standing order for naloxone. Here in Pennsylvania, we do. This just means that any patient that wishes to keep naloxone, whether it's for themselves or just keep it in their household or carry it with them in their purse, they can obtain the prescription without actually having like a prescription for an opioid or anything like that. So the role of the pharmacist, there are many with naloxone rescue. Not only are we trained to administer it, but it's also our job just to make sure it's stocked regularly to give to patients wishing to receive the medication. And we can also bill it through the patient's insurance. So this definitely increases the affordability of the medication. And I'm sure many of us have also heard that the FDA recently approved of over-the-counter sales for naloxone. The hope is that it will be out by the end of summer, but this will also depend on the availability of the medication as well as your specific pharmacy. But I just thought it was important to note that, so whenever a patient typically comes into the pharmacy, either picking up an opioid, a medication like buprenorphine or other controlled medications, especially if it's like a combination of like an opioid and a benzodiazepine, pharmacists offer naloxone to the patient. And I think it's important to roll with resistance for these patients. Many patients are confused because they're just picking up their opioids. They're not diverting it. They're not abusing it. So sometimes there's a little bit of hesitancy and resistance, even some offense taken. So a pharmacist that I used to work with, he would always use the analogy of a fire extinguisher. So I wanted to share that with you guys because I thought it was extremely beneficial and received really well by the patient. So just treat naloxone like a fire extinguisher. You can keep it in your cabinets. You can keep it out of sight if you need, but make sure everyone in the house knows that it's there. If you have a kid that can get into it, a grandkid, pets even, just really anyone, or if you just get confused and you take too much of the medication and you forgot that you took your morning dose and you take another, just make sure that everyone in the house knows where that naloxone is so they can use it on the child that gets into it, or you if God forbid something bad would happen. So this, once again, was received very well by the patient. So I wanted to share it with everyone because it's very effective. So just in general for medication management, it was once referred to as medication-assisted treatment, or MAT, if you've seen that. We're moving away from that because the term assisted makes it seem like the medications are assisting in treatment in combination with like a behavioral intervention or something like that. However, these are the gold standard. These are the treatment for opioid use disorder and even alcohol use disorder. So we're moving away from the MAT and referring to it as either MOUD or MAUD. And I just wanted to note that at the proper dose, these medications don't affect a patient's physical functioning, their mental capabilities, or their intelligence. So this is where the pharmacist can also play a role by helping determine what the proper dose for this patient may be. In addition, the goal of these medications is actually long-term treatment. So when these medications became popular, they were typically used for acute detoxification only. However, data has shown that relapse rates are very high if it's only used for detoxification. So the goal is, even if it's lifelong treatment, the goal is long-term treatment for these patients, unless a patient wants to be tapered off. Then you could discuss that with either the physician or the pharmacist, because we're also knowledgeable in that. But I think that's just a common misconception for these medications because that's what they were initially used for, but we're moving away from that model and encouraging long-term use for patients. So frankly, MOUD works. These medications for opioid use disorder have been shown to be very effective. Just one study here, I included the reference at the bottom and in the reference page if anyone would like more information, but they just pretty much compared 6 different treatment pathways, from behavioral interventions to medications alone. And based on everything that was recorded and analyzed, the treatment with the buprenorphine or the methadone, those were the only 2 pathways that had a statistically significant reduction in both overdoses and serious acute care utilization to the emergency departments in both 3 months and 12 months post-treatment. So this statistic right here, since it did compare the wide range of services that people do use, it does highlight that the medications are what should be used as the gold standard in first-line treatment for patients suffering from opioid use disorder. So when buprenorphine is initiated in the ED, research has shown that it both increases patient engagement in their outpatient treatment once they're discharged, as well as it decreases relapse rates, overdoses, and those acute care services found typically in emergency departments. So as you can see in the top box, the pharmacist can play a role because, as was previously mentioned, we're the most accessible healthcare provider. We see these patients on a regular basis, if not daily, for a lot of these patients. So to initiate buprenorphine at the standard doses, they must be in active withdrawal, or else it will send the patient into precipitated withdrawal, which is very unpleasant. So anywhere from 12 hours to 72 hours, we've noticed fentanyl is a little longer acting than that. It can stay in the patient's system, but in general, that 12 to 72 hours is the range depending on which opioid the patient's taking. So if a patient comes into the pharmacy and we notice that they're obviously experiencing withdrawal symptoms, we can refer them to the emergency department, because as says right here, the buprenorphine does have beneficial effects on long-term retention and just reduction in those overdose rates. So I also wanted to discuss buprenorphine microdosing, because this is where the pharmacist can also play a role. So microdosing, it actually does not require the patient to be in active withdrawal. They can actually have a little bit of opioid in their system while you're initiating the buprenorphine, and it won't send them into the precipitated withdrawal because you're introducing such small doses. So pretty much just how this works, you're slowly tapering that opioid down as you're slowly tapering up that buprenorphine to create a bridge of typically about 48 hours. And as the days go on, you slowly increase the dose. Typically 16 milligrams will stabilize the patient. However, like I mentioned with the fentanyl, we have been seeing higher doses needed. The typical doses are either 16 or 24. You can also go up to 32 milligrams. However, buprenorphine has a ceiling effect. So we've seen that ceiling effect typically comes in at about the 24 milligram dose. However, with the changing seasons, with the fentanyl contaminating everything, depending on your patient, they may need the higher doses. But the takeaway here is really just that we can help the patients, even if they're not experiencing that withdrawal. If they are looking to receive treatment right now, we can refer them, and the pharmacist can help them, usually in an inpatient setting, without microdosing. And then, as I mentioned, we just want to continue this daily dose that they have found works for them until they either wish to be tapered or we just keep it on. So the X waiver recently has been removed, which is an amazing step in the right direction. So beginning this year, prescribers, as long as they have a valid DEA registration along with the authorization to prescribe the buprenorphine, we no longer have to apply for or possess that data waiver, and that 30 patient cap has been removed. So this right here just greatly increases, one, the amount of practitioners able to prescribe the buprenorphine and the amount of patients that can receive the buprenorphine since those caps have been removed. There are additional training requirements. I included that link right there. It should be at the end of the presentation as well in the references for those specific training requirements and more information on that. So how the pharmacist role works really just depends on which setting they're in. So this is not an all-inclusive list. I just wanted to touch upon a few. So like in the inpatient setting, pharmacists can deliver those medications as well as counsel on them. And as was discussed, we are the gatekeepers of transitions of care a lot of the times in the pharmacy. We are really the only thing that doesn't change in that patient's care if they're moving from department to department. And even once they're discharged, we can still keep in contact with certain patients. So ensuring that that buprenorphine, since it is meant to be long-term treatment now, is continued throughout their healthcare journey, that really we can play a major role in that aspect. Regarding both outpatient and community, I think it's really important that pharmacists educate not only patients, but also staff on the medications for opioid use disorder, as well as just normalize it. If a patient's coming in, rather than greeting them in a negative way, if you see that they're taking buprenorphine, encourage them. Be like, wow, that's awesome. Like, how are you doing on it? How have you been doing? And just congratulate them on working towards bettering themselves and their health. I think that is a huge way that we can break down the stigma and the barriers that stop patients from getting the help that they need, and that's so easily accessible nowadays with these medications. In addition, I wanted to touch upon the fact that depending on which state you're in, pharmacists are authorized to administer long-acting injectables. This can be either for buprenorphine or for naltrexone, actually. These injections typically last about once a month. So typically every 28 days, the patient will receive the medication. And a pharmacist I was recently working with, she mentioned that she likes these because that patient, when they receive that injectable, they're deciding for the next 28 days that they're going to abstain from using drugs. And I think that's such a powerful thing, because versus every morning waking up deciding whether you want to take the medication, long-acting injectables, it both increases convenience because you're not taking a medication every day, and it's just kind of a commitment to the patient that they will work on bettering their health and abstaining from using the opioids, or for naltrexone, it might be alcohol, or anything to that extent. So like I said, depending on which state you're in, this will vary, but that is something that I don't think many people are aware of, that we can have a major role in. As well as just in community, just ensuring that the medication's in stock. It would be a nightmare if your patient came in looking for buprenorphine because they're experiencing withdrawal symptoms, or because it's been maintaining them for years and we don't have it in stock. So managing our inventory and ensuring that there's an appropriate stock for the amount of patients, I think, is a really vital part of the pharmacist role, as well as just working with the insurance companies and making sure that not only the buprenorphine, but also that naloxone goes through the insurance, and you will troubleshoot the rejections if they arise, just to help increase the affordability for patients. So this was a study. I also included the link down there for anyone interested in any further information, but it was done in Rhode Island, where pharmacists had a collaborative practice agreement with physicians, where buprenorphine was inducted in pharmacies rather than in a clinic. So the results of the study showed that retention of care when it was initiated in the pharmacy was actually higher than that of the typical care that you would receive in a doctor's office. And there were no deaths or serious unanticipated adverse events that were reported. So I know a lot of people are hesitant because they aren't sure if the pharmacists have the capability or the knowledge to do so, but there weren't any adverse events that were reported other than what are typically seen in any setting. In addition, the naloxone was dispensed to over 36 people, so that just increased the access of the life-saving medication. And I think this is amazing that pharmacy-based induction, it actually promoted access of the medication to patients that might have otherwise not had this access. As was previously discussed, we are the most accessible healthcare provider, so there's no copay when you come into the pharmacy to talk to the pharmacist. We work with the insurance companies right there. 90% of patients live within 5 miles of a pharmacy, so that transportation barrier is broken down. So this study just kind of highlighted the impact that pharmacists can have on buprenorphine and just patients in general that you might not otherwise see in your practice setting. And finally, I just wanted to end with the fact that pharmacists have the knowledge, the training, and the skills to monitor the patients. As I mentioned, we see these patients typically 5 times more than any other healthcare professional. So if we see that they are experiencing symptoms, that's a deterrent for them to stay on this medication when they don't receive the symptoms if they go back to using heroin or their drug of choice. So we can reach out to the prescribers for them, or as Hannah mentioned, we're trained in over-the-counter medications. There's a whole aisle right at our disposal to help make a referral to an appropriate over-the-counter medication for those patient symptoms. We also, as I'm sure many of you know, pharmacists can round with the interdisciplinary team. So we help with the therapy interchanges, whether that is going from methadone to buprenorphine or vice versa, or really any other medication for that matter. We are trained in that, as well as helping pick the right dose and formulation for the patient. As I mentioned, buprenorphine, there's the long-acting injectables, there's the tablets, there's the films. Based on which patient characteristics a patient has, we might be able to help pick the best medication for that patient for the greatest adherence rates. And then, yeah, like I said, we are just exposed to patients more frequently than any other healthcare professional. So we have an amazing opportunity for follow-up and just monitoring in general. So that was all I had.
Thank you very much, Caitlin. And next up, we have Temple Coldren, and Temple is going to talk to us, excuse me, about pharmacists, the role of the pharmacist in long-term follow-up and maintenance. And he will also talk about dismantling stigmas and myths.
So as we already kind of previously talked about, pharmacists are responsible for dispensing the medications used in the maintenance treatment of substance use disorders. So like naltrexone for alcohol use disorder or buprenorphine for opioid use disorder, as well as we can counsel patients on things such as drug interactions, adverse effects, or even the directions of the medications. We can also talk to the patient if they have any concerns about these medications. And as Caitlin touched on, it is essential for pharmacists to try to keep these medications in stock. Maintaining medication adherence is crucial for the success of long-term maintenance treatment for substance use disorders. Pharmacists can provide education on the importance of medication adherence, offer strategies to remember to take medications like the classic pill box, or now they're even making apps that can help with this, and discuss potential barriers that might affect adherence. Pharmacists can evaluate patients' symptoms and assess medication effectiveness. We can collaborate with healthcare providers to make necessary dose adjustments. Pharmacists can refer patients to other healthcare professionals if needed to help with the patient's medication management. And overall, a big thing is we can collaborate with the healthcare team, including individuals like physicians, nurses, and social workers, to ensure comprehensive care for patients with substance use disorders. As a pharmacist, they can be the drug expert for substance use disorders on the team, and they have found that collaborative care improves patient outcomes and reduces the risk of relapse. Pharmacists can assist in connecting patients to needed resources such as counseling services, support groups, or community organizations that offer recovery support. For example, pharmacists should be knowledgeable about local support groups in their area, such as Smart Recovery or 12-step groups like AA or NA, as well as knowing the scheduling and location of these support groups in order to provide the best information and resources for these patients. They can also help direct patients to social services such as housing assistance, employment support, or even legal aid, which all might be necessary for an individual in their recovery journey. Despite the known clinical benefit, many commercially insured patients are not being treated with medications for opioid use disorder. This truly highlights the need for strategies to improve access to and coverage for these treatments. There are numerous barriers that limit the use of medications for opioid use disorder, such as the fear of stigma and discrimination, limited access in rural, underserved areas. There are many places in the United States where there are no healthcare providers that have the correct training or authority to prescribe many of these medications. And this causes this causes patients to travel long distances in order to receive treatment. A great example of this is methadone clinics. On average, in a rural area, it takes 6.3 times greater to get to the clinic compared to an urban area. There are also knowledge deficits among clinicians, and only a few addiction treatment programs offer all forms of medication for opioid use disorder, as well as insurance coverage, prior auths, and cost. Overall, pharmacists are very accessible in their communities and can play a crucial role in advocating for and implementing strategies to overcome these barriers and improve access to medications for opioid use disorder for patients. So now I'm going to talk about dismantling myths and stigma. As you've all probably heard, the myth addiction is a moral failing, or when you're giving a medication, you're just enabling them or trading one addiction for another. The fact is, substance use disorders are a complex medical condition. Some ways we can dismantle these myths and stigma is through education. Universities and other educational institutions can revise their curriculum to include comprehensive education on substance use disorders, addiction medicine, and approaches to reduce stigma. Continuing education, shout out to IRETA, can focus more on stigma reduction strategies, effective communication techniques, and cultural competence to improve patient care and reduce the perpetuation of stigma. We can also use non-judgmental approach in language. You can use an empathetic approach, and instead of using labels like addict or junkie, pharmacists can use neutral and respectful terms such as individual with substance use disorder. And pharmacists in this area can lead by example. And I just put a little chart to the right just to show some potentially stigmatizing languages to avoid. So things like junkie, addict, user. Another way you can dismantle myths and stigma is through community outreach. We can offer educational presentations or workshops on substance use disorders and stigma to various community groups. We can be directly involved in harm reduction initiatives in the community, such as naloxone distribution programs and safe disposal programs for unused medications. And we can actively participate in community health fairs to engage with the general public and provide information about substance use disorders, local services, and stigma reduction. I know as a Duquesne student pharmacist, we participate in a community health fair every year, and it's a pretty big hit.
Thank you very much, Temple. Back to me for wrap up. So I'd like to talk a little bit about some of the barriers that get in the way and how we can overcome those as pharmacists. So the way I see it, there are two big buckets, two big areas that prevent or are barriers to people seeking care. That would be stigma and access. So stigma, of course, prevents patients from seeking care, but it also unfortunately gets in the way of practitioners providing that care. Access is a huge problem. There's a paucity of healthcare providers in this space. We all know the cost of treatment and insurance barriers. Anybody who's trying to navigate the insurance system knows that there are barriers that get in the way of being able to provide help. Wholesaler caps is actually a thing, and so I'm going to talk about that in a few slides here. Equitable and adequate compensation for the provision of care to practitioners is important, and regulatory hurdles present a barrier as well. So Temple touched upon stigma, and so just very briefly as a recap, self-stigma prevents individuals from seeking care because of the guilt and the shame that they experience associated with the illness. There is such a thing as associative stigma. So this is stigma that loved ones experience based on their relationship to the person with a substance use disorder. It makes them reluctant to talk about it. It makes them reluctant to seek help for themselves and for their loved ones. In fact, I had a woman share with me just last week that her family ostracized her and did not provide her with support because of her son who was experiencing a problem with a substance use disorder. So they can be very lonely. And then provider stigma, and that's a shame, you know, that folks who are healthcare practitioners have stigma and are judgmental and condescending towards patients with substance use disorders. There are still too many providers that view substance use disorders as a moral failing or a lack of willpower and do not understand it as a true illness. And then, of course, there are the aftershocks from the prescription opioid crisis. So a lot of practitioners are gun shy. They feel like they've been duped through deceptive marketing practices when it came to the opioids because they were prescribing them as they thought they should and got caught up in the practice. So they got caught up in the crisis. So they may feel guilty about unwittingly contributing to this current crisis. They're gun shy because of these huge settlement awards that were granted when indeed they were acting in good faith. So practitioners don't want to be part of another or a next crisis, right? Especially amongst those who might believe that buprenorphine or methadone is simply a replacing one addiction for another. But we do know that MOUD, medications for opioid use disorders, work. We know they save lives. So pharmacists can help to dismantle that myth associated with buprenorphine and methadone. And then facilitating access to care. So HRSA projects that we're going to have a shortage of over 24,000 behavioral health care providers by the year 2030. That's huge. And the X waiver removal, although that was a really great thing that happened at the end of last year, unfortunately did not result in the big jump in the number of providers that are willing to prescribe buprenorphine. So our hope was that more primary care physicians would be willing to prescribe buprenorphine and lower those barriers. We're not seeing as much of that as we had hoped for. So how can pharmacists help with that? Well, you've already heard repeatedly that 90% of the population lives within 5 miles of a pharmacy. And Caitlin provided us with an introduction to a research study that was conducted by pharmacists in Rhode Island in community pharmacy settings. And we did find out that pharmacy-based buprenorphine induction resulted in significantly higher retention rates of persons in treatment versus standard care. Again, folks may feel that it is easier to walk into a pharmacy for help rather than trying to get an appointment, or maybe they feel stigmatized by going to a treatment center or seeking care from an addiction center. So you can see 1 month out, there's a huge increase, 89% versus 17%. Now, we don't know long-term results, but this is very encouraging. One of the problems, though, is that most states, even though they allow for collaborative practice agreements, do not allow pharmacists to begin therapy for controlled drug substances or to make adjustments to doses of controlled drug substances. So that's a barrier that hopefully we can overcome with legislation and changes in regulations, even when it comes to collaborative practice agreements. So again, a barrier that hopefully we can help to dismantle. Boy, we've all dealt with insurance, right? So insurance is very difficult, very frustrating. First of all, we have to make sure that our patients qualify for care. And then if they qualify for care, maybe we have to recertify them to get them length of stay. The most typically that we can get from insurance might be 28 days, when we well know that patients do better when they can stay for 90 days. So length of treatment is an issue with insurance. At the pharmacy level, we're dealing with prior authorizations for medications. So we might need prior authorization for the buprenorphine, or there might be limits on the strengths that we're able to dispense, or the quantities, or the length of time. And then think about the individuals who don't have insurance. So this population in particular is at very high risk for unemployment and homelessness. Pharmacists can help to navigate some of those insurance barriers. Regulatory hurdles. So there is such a thing as wholesaler caps. So the DEA has tasked wholesalers with what we call suspicious order monitoring, or SORS. So wholesalers will look at past history from an individual pharmacy to see how much of a controlled drug substance they've been ordering. And they will base future orders on those numbers. If a pharmacy begins ordering something in quantities that deviate from their normal pattern, there's an unusual size, unusual frequency, that wholesaler may put a stop on providing that medication to the pharmacy. So let's say you're a pharmacist and you're operating in an area, and now you have an addiction provider specialist who moves in next door to you and sets up a new practice in your area, so that now they begin prescribing buprenorphine for more patients. That could become a problem for you, because now you might not be able to get the quantity of medication that you need to be able to provide to those patients. So in this particular instance, what could a pharmacy do? Well, number one, if they know this in advance, they can alert the wholesaler ahead of time to let them know and provide a petition. Hey, just wanted to let you know we're going to see an uptick in the number of buprenorphine prescriptions because we have a new provider or new practice that opened up in the area. So that's a proactive way of doing that. With a small wholesaler, it's usually pretty easy to document that. But think of the big players who are now supplying buprenorphine to a large number of pharmacies. It's going to be more difficult for you to get an exception from them, simply because of the large number of pharmacies that they're dealing with. So in the short term, a pharmacy could use a secondary wholesaler, but a lot of times they have to have a minimum quantity or a minimum price order from them, which might create a barrier. They could refer their patients to a nearby pharmacy to help bridge them through. This is probably not best practice, right? Because now you're referring your patients, which is very inconvenient for them. They have to go to a different pharmacy. It's certainly not good business practice for the pharmacy itself. Or finally, what some pharmacies are doing, and again, is very unfortunate because it creates a barrier. Another thing that they might do is restrict their dispensing of buprenorphine to their known patients, so that they make sure that they have enough on hand for the people who are their regular customers and regular patients who are being maintained. That limits the supply for new patients. And then there's the issue of diversions. So pharmacists on the front line do have to deal with this. Of course, the proper prescribing and dispensing of controlled substance is really based upon the prescribing practitioner. But here's what's important and what I highlighted for you. A corresponding responsibility rests with the pharmacist who fills the prescription. So a pharmacist could be subject to prosecution if that pharmacist knowingly dispenses to an individual who's engaged in diversion. So again, another regulatory hurdle that pharmacists have to monitor and overcome. So it does place that frontline pharmacist into a difficult position. And then provider status. So I'm going to talk about this for a little bit. You probably are not aware that pharmacists are not recognized as healthcare providers at the federal level. And I'm sure many of you are thinking, of course, like pharmacists are healthcare providers. Like, what do you even mean by that? So the Social Security Act does not recognize pharmacists as healthcare providers for Medicare for purposes of reimbursement. Many states do not recognize pharmacists as healthcare providers for the purpose of reimbursement. So that means right now that pharmacists in most states will rely on dispensing medications in order to generate revenue. So as you can imagine, over the years, because of insurance companies, those margins have really gotten squeezed. So pharmacists don't make that much money on dispensing. And in some cases, they actually lose money when they dispense some of these higher priced medications. You know how much time it takes to screen a patient for a substance use disorder. It takes quite a while to go through medications with the patient. It takes a while, quite a while, to do motivational interviewing and to refer patients for treatment and to maintain them and coach them. So these are all really important things that pharmacists are qualified to do. However, there's no reimbursement associated with that. The problem is without a revenue stream, it's difficult to have enough staffing to be able to offer these clinical services. So we recognize this issue for our profession. You can see here in this photo, and there's Hannah in the front row. You can see that we routinely take our pharmacy students every year to the state capitol in Pennsylvania or to the US Capitol in Washington, D.C., to advocate not only on behalf of our profession, but also on behalf of our patients. And we typically talk about the opioid crisis and the ways in which pharmacists can assist and provide some help to help alleviate the crisis and serve our patients. So in summary, hopefully you learned today that pharmacists are some of the most accessible healthcare practitioners. Pharmacists can be a very valuable member of the healthcare team. We can engage in screening, brief interventions, and referral to treatment as frontline providers. Pharmacists can provide motivational interviewing to move individuals towards behavior change and support their long-term recovery through coaching and follow-up. Pharmacists can provide medication induction and management, and we also can help to dismantle the stigma that gets in the way of recovery. So I want to thank you very much for your participation in our webinar today. And we, myself and my students, were happy to answer any questions that you might have. And Marla, I'm going to ask you to perhaps screen some of those questions for us.
Sure. So some were coming in throughout the presentation, and I kept track of those. There were, first of all, there were lots of good comments. One person in particular said, "Love that you are involving pharmacy students in these types of presentations. Another role of pharmacists in SUDs is educating student pharmacists about the topic area to increase knowledge and reduce stigma," with a smiley face. So
Great.
one person asked, "Is there a pharmacy that has done Espert that we know of?" So I guess the question is, are there pharmacies? I guess they want to know about pharmacy, like, is Rite Aid doing Espert?
Mhm. So I think routinely across the chain, no. I think sporadically with individual pharmacists and pharmacies that have an interest in doing that, yes. Our advice to pharmacists that want to implement screening is that you incorporate it into your regular flow. I know that Sean mentioned, you want to be careful that you're not making patients feel stigmatized. So one way of doing that, particularly if it's a new patient, is as part of the intake. So normally you're going to do medication history. You're going to ask about allergies and get some information on the health background. It's an ideal way to incorporate these kinds of questions, the pre-screening questions, and then if warranted, to conduct the full screen. There was a study that I believe is ongoing here in the city of Pittsburgh, where they are working with pharmacies to implement and incorporate Espert as part of their routine practice. I wish it were more widespread.
All right, thanks for that. Michelle just asked, can pharmacies partner with prevention groups to increase Narcan naloxone training?
Absolutely. So I don't know, I'm going to allow my students to jump in if any of them want to. But in Pittsburgh, we have Prevention Point Pittsburgh. I know that our student pharmacists routinely volunteer there and provide help. Hannah, maybe you can comment on that. You've been involved in that, correct?
Yeah, so with an organization that I kind of worked with, well, I guess I was vice president of at Duquesne, we did like a service outreach program. So we went and kind of helped them package up. They do safe medication like packages. So we kind of all were sectioned in different groups, and some of us labeled and shipped out Narcan or naloxone, and then some of us kind of helped to put together the safe use kits for them to take. And Prevention Point, which is Pittsburgh based, they do have other locations around, I think, Pennsylvania. They have like a van that they set up in the same spot every week for people that are using substances to come and get safe supplies to as like a harm reduction measure, pretty much.
And I know that, we have a relationship with Allegheny County Health Department and Prevention Point here in Pittsburgh. And so routinely we can get a supply of Narcan through grants. So my students have accompanied me on multiple outreach programs in the community. Where we talk to community members about how to administer Narcan, what it's used for, how it works, and then we're able to provide them with doses of Narcan that they can take home with them. So yes, we absolutely partner with those associations.
That's so great to hear about those partnerships. So a few questions came in about motivational interviewing, so I'll just group them together.
Okay.
One person asked, you mentioned pharmacist certificates in SUD and motivational interviewing. Can you share more? And then the other question was, what specific trainings for motivational interviewing have you seen?
So we actually developed 2 different certificate programs here through Duquesne University that we make available to practitioners, not just pharmacy, but practitioners for multiple healthcare disciplines. One of them is called Identification and Referral. So it consists of both an online and in-person, and that's where we talk about screening and we talk about motivational interviewing. So students and practitioners alike can take advantage of that and learn how to use those techniques. We do hands-on, so they get an opportunity to practice. The second one is treatment and alternative approaches to pain management. So we do have those certificate programs that we offer. In addition to that, in the pharmacy curriculum, students learn how to do motivational interviewing. So that's part of their education and training. That is not specific to substance use disorders. Motivational interviewing is good for anyone, who needs to maybe work on behavior change. So for instance, a diabetic patient who might need to learn how to monitor their diet and exercise. So motivational interviewing is good for a vast array of different disease states, including substance use disorders.
All right. And then I think we just have maybe 1 or 2 more questions. Sorry, let me pull that up.
Sure.
Another question was for screening. Do you recommend screening each and every patient who comes to the pharmacy, or just those potentially at risk for who are receiving narcotics?
Yes, so that ties back into one of the questions that we had earlier. I think, again, so that you're not stigmatizing patients is probably a good way to incorporate it into your standard practice. That's what we would recommend. Although if there is an issue, where you see someone might, those red flags that Sean had mentioned, might be a good way to start having a conversation with patients. Would it be okay? And this is a great way. I always ask permission, right? First step in motivational interviewing. Would it be okay if I asked you a few questions about your drug use or alcohol use or what have you? So good way to maybe start introducing those pre-screen questions, and then you can move on to a full screen. And then after they complete the full screen, you can ask for permission to go over the results with them. Meeting people where they are.
And then just one more question. So someone asked, what do the regulations look like in Pennsylvania for pharmacists managing MOUD with a CPA?
So in Pennsylvania, we have restrictions with the controlled drug substances. We would have to have a supervising physician. In Pennsylvania, we cannot initiate medications. So with collaborative practice agreements. So if we had a collaborative practice agreement with a supervising physician, we would be able to make adjustments or monitor, but not initiate. And that's a barrier, right? We saw that pharmacies had great success in using or implementing buprenorphine induction. So that would be a regulatory hurdle that we would need to overcome.
All right. Those were all the questions that had come in. Thank you so much, Dr. Astle and Dr. Astle's students. This was so great to hear from everybody. If folks who are on the webinar want to stick around just for another second, I'm going to go over some last minute items about CEUs. Thanks so much again for all your great questions and for attending the webinar. We would like to remind all participants that a PDF of today's PowerPoint, along with the recording of today's presentation, will be uploaded to the webinar library located on IREDA's website sometime next week. Once we have these resources posted, a link will be sent to all of today's webinar registrants. I now want to remind you of our evaluation and CEU process. You will receive several follow-up emails from us. The first email will include a link to the evaluation and step-by-step instructions on how to obtain CEUs. Please note that it will take up to 48 hours for your CEUs to become available because we have to cross-check your attendance records. We would like to especially request that you fill out our evaluation. It should take no more than 2 minutes of your time. Again, we want to thank everyone for taking time out of your day to participate. If you have any questions at all, please email us. The email address again is info@ireda.org. And with that, I will conclude today's webinar. Thank you so much and have a great rest of your afternoon.
Thank you all.